get it right? He said if there's another Hayung in the United States, it's related to him. They're related to him.
Not lying.
So Kyle holds a Bachelor of Applied Science Business Administration with a minor in marketing and a vascular, general cardiac, and obstetrical sonography degree. He studied at University of Texas Pan American, which is now UTRGV, Virginia College, and Southwest University. Kyle is a game-changing business leader who can look at things and determine the value add immediately, and then develop the right team and execute swiftly in all areas. He has raised over $10 million for outside companies and is bootstrapped and built 3 businesses in the past 10 years that have had significant financial and intellectual property, and has done over $10 million in reoccurring revenue. So I'd like to welcome you, Kyle.
Thank you, Lori. First off, thank you guys for taking the time. Lori, thank you for putting on such a good event. Good evening. Today I'll be showing you how we are currently disrupting the health and wellness delivery models through people that are suffering from chronic diseases. There are about 10,000 Americans a day turning 65. Chronic diseases affect approximately 133 million people in the U.S., or 40% of the population. 7 out of 10 deaths occur from chronic diseases, and about 50% of the people that have chronic diseases don't receive the recommended healthcare services that they should. In 2020, healthcare was 19.7% of the U.S. GDP, its all-time high. The main problems broken down are 2 main segments: doctors and caregivers, and patients and family members. Most healthcare organizations are not taking proactive preventative measures with their patients. They are operating in a reactive treatment-based model. Physicians and their staff have busy schedules, dealing with in-office visits. They deal with high staff turnover and are unable to reach patients due to limited IT infrastructure and staffing issues. Most do not have the time or experience to implement these types of solutions and are lacking the systems, processes, and protocols, not just technically ready for virtual care management services. Patients, especially the underserved, have issues with getting access to care they need. They deal with long appointment lead times and lengthy commutes. Patients also can be limited to technical literacy, lack of needed support, and a lot of time require assistance with transportation to and from their appointments or pharmacy. We eliminate these issues with SmartCare360. Now let me explain how MRG Health solves these problems through virtual care management solutions. Our virtual care management solution improves access to care, making the palm of your hand into a smart clinic with personalized disease-specific care pathways and health and wellness programs. We increase patient compliance through our direct outreach programs. Further, our program personalization is based on the patient's circumstances. It allows us to tailor the program to serve the patient meeting their specific needs. Our system capabilities allow us to make actionable decisions with this data and has been proven to improve patient outcomes and lower healthcare costs. We create immediate savings for insurance carriers by reducing the need for emergency services. This also creates revenue opportunities for healthcare organizations through new billable care models. In addition, our revenue cycle management solution assists in insulating financial risk because we monitor and control the revenues. Through our system, we can seamlessly verify patients' insurance for proper coverages, facilitate medical billing and coding, claim submission, collections, and any denials or appeals for optimum reimbursements, all electronically. Our proven systems create profitable, sustainable recurring revenues that require minimal time from the doctors and their staff with no upfront or out-of-pocket costs. This will immediately improve access to care issues, creating better patient experiences and improved patient outcomes. We also assist in capturing Medicare incentives for healthcare organizations, which is about 5 to 7% of Medicare collections. We create immediate revenue opportunities for healthcare organizations. 400 patients will generate about $120,000 in net profits per year in passive recurring revenue. This will also increase practice efficiency by up to 50% through automated scheduling, reducing appointment cancellations, no-shows, and other day-to-day administrative tasks that our program removes out of the equation for chronically ill patients. Here's an infographic of some of the platform's capabilities. Our key differentiators are that we are intensely focused on patient experience, feedback, and adoption. We are consistently finding ways to drive patient compliance, preventing chronic episodes through monitoring, triaging, and care coordination, all while lowering healthcare costs for insurance companies. Speedy and efficient service is driven by our fully integrated revenue cycle management and gamification capabilities, documented processes and protocols in all current departments, scalable IT infrastructure, and having our sales and delivery processes ready to scale, which will allow us to move very swiftly and expand rapidly throughout the marketplace. Here we break down our responsibilities versus the healthcare organizations. We handle all patient onboarding requirements, all virtual care management, patient monitoring, clinical administrative documentation that meets insurance audit requirements and reimbursement guidelines. The only responsibility that the healthcare organization has is to review non-compliant charts. It only takes about 2 to 3 minutes per chart. Here you see our executive management team and active medical advisors. I focus on product development and strategic initiatives. I have a degree in business administration and a degree in vascular, general, obstetrical, and cardiac sonography. I've also bootstrapped over three businesses in the past 10 years with one successful exit. And I've taken a molecular genetics and pathology lab to market that has DNA testing that's FDA approved for cancer, preventative diabetes screening, and COVID. Renee, he assists with strategic development and compliance and regulatory initiatives. He was the director of strategic development for DHR for 14 years, and he's now the vice president of Rio Grande Regional. David is a senior executive for Dell for 25 years and primarily assists with strategic planning and optimization of day-to-day operations. Dr. Duran focuses on development initiatives. He's a cardiologist by training and a medical director at MD Anderson in Houston. Dr. Rodriguez focuses on strategic development initiatives. He's a gastroenterologist and has a background in biotech. And Shafiq is our managing director, secretary of the board. He's a serial entrepreneur and the founder of a business incubator based in Houston. Was on the advisory board of the Houston Technology Innovation Center for 3 years and has a bachelor's in science from Purdue and a master's degree in computer science from the University of Houston. We were founded in 2019 after significant research on new care models approved through state and federal legislation. In 2020, we completed R&D software capabilities requirements that aligned with over 10 PhD thesis studies, defining use cases within applied vertical markets. We also completed clinical efficacy testing and business model contracting validation. In 2021, we went to market in stealth mode, surpassing $20,000 in monthly recurring revenue. Our team consistently enrolled 35 patients per day, and we exceeded our new client contract goals with technically no sales department. In 2022, we billed over 350 patients consecutively 2 months in a row. We're on track to bill over 1,500 by March 31st. We also improved processes and systems. To enroll 50 patients per day and executed on 3 more signed contracts that tie to an additional 6,000 patients in our backlog. We've also expanded numerous capabilities within SmartCare360, which has improved patient compliance and overall metrics consistently. Here you see a snapshot of our key milestones and metrics by patient and by revenue, which we are ahead of schedule on. This really summarizes what our team is actively executing on day in, day out. By April 22, we should 10x our January's numbers, and we'll touch on more in a couple slides here. This is a breakdown of our current clients, which are private practice subspecialty groups. We have a CRM with sales and marketing automation software with over 15,000 private practices, information ready to be marketed to, and hundreds of channel partner opportunities via electronic medical records, medical billing and coding companies, or lab and pharmacy groups. Our initial market is Texas, broken down by major metros with the number of private practice groups and the number of patients with 1 or more chronic disease in the surrounding counties. Studies show that by 2025, the number of people using remote patient monitoring is expected to increase from 7 million to over 50 million, reaching a $30 billion revenue just in remote patient monitoring by 2023. If we are successful with our initial virtual care offering, we'll have positioned ourselves to expand our wallet share of each patient medical spend by capturing additional vertical market opportunities that have use cases that we have use cases and applications for. We could further expand our total addressable market down the age ladder by addressing people that are 55 or older with private insurance. We plan to expand into these opportunities in Q1 or Q2 based on our of 2023 based on us meeting our company milestones. We currently are raising a seed round of $500,000 via Safe Note at a 10% discount. There's $275,000 left in the round, which was opened less than 30 days ago. The funds will be used to drive revenue through onboarding patients that are in the backlog, to close 20 new contracts that would represent 50,000 patients to be onboarded, and to fund working capital and minimal ongoing product development. We commit to enroll a minimum of 5,000 patients, resulting in at least $500,000 in monthly recurring revenue with the funds raised in this round. We developed and tested health informatics training software that we received a grant from the state of Texas on, and they recently contacted us that there's another available grant that we'll be meeting with them this Wednesday. The financial opportunity is significant based on our historical numbers and a 1 to 3 year projections. We're forecasting that $100,000 investment could potentially create a 25 to 30x return. With the right range of big data that we ingest, our recurring revenue model, which includes a wide range of M&A prospects. Down to the right, you see who we have in our radar, and we're basing our evaluation off of our historical numbers and 2024 forecasts and projections conservatively at $98 per patient per month, and this does not include the 7% that we charge for revenue cycle management. So we're looking at a 5 to 10x multiple that could be valuation of anywhere from 150 to 300 million within 3 to 5 years.
Okay, well, we're at time. So do we have any questions for Kyle?
What's your pre-money valuation at this point?
When we initially started, we did the pre-money evaluation at $5 million. We have a $20 million cap on our Safe Note, and by April we should be doing anywhere from $450 to $500,000 a month, where we should be able to hold a $15-20 million valuation. This is all through new care models that Medicare, Medicaid, and now most commercial payers are paying for.
Anybody doing this now?
There is competition in the market. We've been in stealth mode, and we have basically a research facility down here where we've really gotten the sales and deliveries, or the service and delivery side of it down to where, I mean, there is other people in the market doing this. Yeah, to answer your question.
So is this comparable to like Hilo?
Hilo.
Hilo is the doctors you sign up, it's a web portal.
Oh yeah, so that's more of a scheduling kind of.
Because I can pull up, all my exams and everything on there, so
What
how does that differ from what
Sure.
what you're presenting here?
So Hilo does not have the disease-specific care pathways or protocols, and they're not really a health and wellness program. We integrate with every electronic medical records out there, and we're like a layer in between the doctor's office and the patient. The doctors and their staff just don't have the time to meet or to serve all of the chronically ill patients that they have in their electronic medical records. So we act as like an extension to their care team or their office. And with the doctor, I mean, most healthcare organizations, they have thousands of patients in their EMR, and a lot of times, a lot of those patients haven't even been in the office in a year or two, so we usually go back 3 years in their electronic medical records, mine all the patient data, and then we act as like an outreach component for them.
What would it look like for me as a patient? Take me through whatever my disease you want to give me.
Yeah, so we have disease-specific care plans that are built around the patient's social determinants of living, social determinants of health. We take into consideration their availability, their technical literacies, all of these different things that would affect them from actually using it. We've learned a lot over the past couple of years to kind of remove those things out of the equation. we now, I mean, it's app-based and it's web-based, so they technically don't need a smart device. All of our devices have cellular technology in them, so as soon as the patient steps on a scale or takes their glucose, it automatically comes through the system. If we don't get a reading from them, we get alerted, and for every 250 patients, there's three people to a care team, two medical assistants and one nurse. So I mean, we have over a 90% adoption rate and less than a 10% churn every month, so it's.
Couple things. One, on your patient outreach, it says text, is it?
So we have a clinical call center, so it's a lot by phone, it's by text. Our system also, like whenever we go into a patient's chart, it tracks all of it, because all of these CPT codes are time-based. There's about 25 different CPT codes that we built the platform around those reimbursement guidelines. So all of the CPT codes are time-based, and our system, as soon as a caregiver clicks on the chart, it automatically starts the time. As soon as the time meets those reimbursement guidelines, it pushes out the claim data.
Okay. And then, when you said disease specific, is there a wide array of?
So before pulling any of the technology,
Focus group?
yeah, before pulling any of the technology together, we actually aligned the software requirements with about 10 different PhD thesis studies that are broken down by major issues in healthcare by vertical market. So because I have the background in vascular general, obstetrical, and cardiac sonography, I built these care pathways or the platform so that it's specialty or disease specific. So we have care plans for every major chronic disease. They're all standard protocols and guidelines, but what we do is we stratify the risk of the patient, so we have different levels of care plans based on the patient's risk.
Are you familiar with care message or?
Care message?
Care message.
I've heard of care message.
With remote physiological monitoring, the biggest expense is going to be the device for the clinic. Do you all have any, do you provide the device?
Yeah.
What type of devices are you currently providing?
So we integrate with over 250 different devices. We're device agnostic. It's a very capital intensive industry. All of our devices are FDA, we integrate with, are FDA approved, other than Apple, Fitbit, and Garmin, which are just activity trackers. As far as the cost of the device, we have third-party financing solutions, so we don't really have to use our money for these devices. We can spread that cost out over 6 months, and there's actually CPT codes to bill for the device. So there's really no overhead or out-of-pocket expense for the healthcare
Do
organization.
you all bill for that device yourself, or does the
Yeah.
clinic actually have to?
No, we facilitate all of the billing. We have our own payer contracts that we bill on, and we'll put the doctor under our payer contracts and bill on their MPI number. Or we just bill on their MPI number, and then we have a lockbox system where the money goes into. We have a management fee that we take the majority of the revenue, and the doctor, healthcare organization gets a piece.
So with the strategy that you have, it's really an aggregation strategy, because there's really, I mean, you're agnostic, so you don't have the device. What is your strategy to go out there and get physicians to sign up, and while you're competing against the other companies that are doing this?
Well, what I've seen is most companies that are doing this don't have the billing or revenue cycle management. They also, they're usually just offering one device or one kind of disease service, to where ours is disease specific or specialty specific, so we have all of the different chronic diseases that we have care plans for. As far as the device agnostic, it just really helps us with supply chain and having, like, not having a bottleneck there. So, and it's very competitive too. The new devices are always coming out, so we just get their API or their SDK and become like a reseller or channel partner and be able to distribute those devices.
So your revenue will be based on like the number of physicians or number of clinics or
Number of
signing
patients. So for every contract that we get or every practice or healthcare organization that we work with, there's at least 2,000 to 3,000 patients that qualify. You just have to have one or more chronic disease in order to qualify. And so that's why we mine the EMR data, and we put a list together of all the patients that qualify, and then get that to the healthcare organization. The doctor signs off on it, and then we go.
When you say qualify for insurance,
Right, yeah, all, Medicare started the program, then Medicaid, and now most commercial payers are starting to cover it.
With remote, with the RPM, you can only do one charge a month per patient.
Yes.
So if you do the reconciliation, I mean, the cardiologist is doing his RPM for daily weights, for example, and you get to the primary care doctor, and he doesn't necessarily know.
70% of doctors aren't
reconciliation?
billing this stuff yet. Like most health organizations or health executives don't really know these care models exist, and they don't have the proper IT infrastructure. They don't have the people, because all of these codes are time-based. You have to spend at least 20 minutes per month per patient, whether it's interactive or non-interactive. And most, I mean, you get 2,000 patients times 20 minutes. They just don't have the people to do it. So we kind of take everything out of the equation. We do it all for them. Becomes a passive revenue stream for them. They make about 20 to 30% of the revenue. We make the difference, but we cover all of those costs.
And so right now, the public health emergency allows you only need 3 vitals per month in order to qualify. Once the public health emergency, which looks like it's ending, is going to be withdrawn, you'll go back up to 15 to 16.
16, yeah.
Have you looked at the devices? So we don't really have a lot of data on that since this RPMs and RGVANs came out during the public health emergency or shortly before it. Have you looked at the devices? Are you going to do the reconciliation for the number of data points per month that are billable?
Yeah, I mean, we have a dashboard where we can see all the patients per care team. We can pull reports where it basically shows who has met the reimbursement guidelines, who hasn't, so we know who to go focus our time on. With our devices, though, the patient doesn't need to do anything other than take the vital. Once they take the vital, they're done. They don't need to like pair Bluetooth or do anything like that. With regards to remote patient monitoring, that's just one of the services. We also do principal care management, chronic care management, and transitional care management, as well as telehealth. So there's 5 different services within one platform, which I haven't came across a platform that has all those.
Tell me about the telehealth, I mean, and the chronic care management, and you do redirection of a patient who's going to the hospital.
Yeah, so that's the whole mission, is to prevent people from having chronic episodes and ending up in the ER. So with principal care, they just need to have 1 chronic issue. Chronic care, they need to have 2. Remote patient monitoring is if you're tracking a biometric. And then transitional care is for pre and post-op procedures to prevent readmissions.
Can you direct the patient though, if they need to go to a certain?
So it's all about care coordination.
ER?
That's the main thing we do, is coordinating the care. I think I'm out of time.
Did anyone else have one more question?